Getting up close and intimate. Totally not taboo with Tracy. Celebrating sexual positivity both in and outside the bedroom.
Hi learner lovers, and welcome to another episode of Totally Not Taboo with Tracy. This is where we get to talk about everything that is taboo around sex and sexuality. Today we have Carren Hughes in our beautiful new environment. She's a physiotherapist, and we're going to be talking about pelvic health and sexual pain. Carren is a member of the a multidisciplinary team of My Sexual Health, and without any further ado, I'm going to introduce Carren. Welcome. Thank you for being on our show.
Thank you for inviting me.
And we're going to have a really great discussion about the taboos around treating patients with sexual pain associated, pelvic pain, association with intercourse.
Right.
So please would you introduce yourself?
Sure. My name is Carren Hughes. I have a BSc physiotherapy degree from UCT, been qualified 20 years now, can't believe it's that long. And I started venturing into specifically women's health and pelvic health in approximately 2013, starting with antenatal and postnatal education, all postgraduate certificate courses held by the South African Society of Physiotherapy, and have subsequently done multiple women's health courses in the hypertonic pelvic floor, which is when the pelvic floor muscles can be very tight, which is what we're going to talk about today, and the hypotonic floor, which is when the pelvic floor muscles can be quite weak, and we deal with things like incontinence, which we won't be talking about today.
Okay.
And this, going into women's health and pelvic health, has been absolutely mind-blowing. Never in my life did I think, when I started doing physiotherapy, that I would be dealing with the pelvis, almost only in the pelvis, as I thought that physiotherapy was predominantly hospital work and running onto the rugby field. So this has been exciting. It's incredibly rewarding, as you can really change somebody's life significantly when you can assist them with resuming a normal relationship, normal sexual behavior, and pain-free.
Yeah. So, the first time I ever heard of pelvic work by a physiotherapist to relieve pain around sexual intercourse was when I was doing my training as an intimacy coach.
Right.
And it was at that stage, almost 10 years ago, that I thought, that's a bit weird. And then the idea of a physiotherapist using penetrative methods, to go inside the vagina, to actually manipulate or massage or whatever it was, I thought, don't know about this, but strange. And then the more I got working with my sexual health, and the more I understood the role of the physio, then it all made perfect sense. It made even more sense to me when I sent a few patients to the physiotherapists, and they, with a condition called vaginismus, which we're going to talk about, and they came back like new people. They weren't experiencing pain anymore associated with intercourse.
It's incredible.
Yeah, so I'm blown away by the job that you do. So please, will you tell us more about it and explain what vaginismus is and other painful experiences with the pelvis?
Sure. It is mind-blowing, and again, never did I think that I would ever be working internally I thought that's just something that the gynecologist does, and that physiotherapists would never delve internally. And that's where things change significantly for how I'm able to help someone, being able to work inside the pelvis and not just outside the pelvis. Vaginismus is a condition that affects, not specifically vaginismus, sorry, painful sex, which is called dyspareunia, affects 1 in 5 women, which is quite a big number. 20% of us experience pain with sex for different reasons. Vaginismus is one of those reasons, and vaginismus is when the pelvic floor muscles go into spasm and prevent anything penetrative. So it could be a tampon, women that are unable to use a tampon at all and unable to have penetrative sex, or anything penetrates their vagina. These muscles in the pelvic floor will also be, the muscle spasm in the pelvic floor will also involve the neural tissue, the nerve tissue, which can result in a hyper alertness or an overactivity of the nerves in the pelvis. This can result in even heightened pain with light touch, and then we're delving more into something called vestibulodynia or vulvodynia, which is a little more complicated and can involve inflammation of the nervous tissue and needs to be diagnosed by a doctor. Vaginismus specifically is what physiotherapists treat predominantly in pelvic pain, and what we do is work not only internally but externally with relaxation. We work a lot in the cervical spine, the neck and the jaw. The neck and the jaw specifically are very related, are commonly related with pelvic pain and vaginismus. That's where we hold a lot of tension. So we're also looking at the causes of fear and anxiety, a history of fear and anxiety that might be involved in the symptoms of vaginismus arising. So working with diaphragmatic breathing, relaxation exercises, meditation, releasing the neck and the jaw, and then going internally into the vagina and releasing the pelvic floor muscles. Working with not only massaging or myofascial release, which is what we'll do internally and externally. If you've ever had physiotherapy for your neck for headaches, releasing what we used to call trigger points, now just focal points of muscle spasm, and that affects the nervous tissue as well as the blood vessels in the area. So by working on releasing the muscles quite gently, we can't be going too hard internally. Gently releasing the muscle tissue will affect the nervous tissue. So getting the nerves to calm down and relax and start communicating the correct information. Often what happens with painful sex, and specifically vaginismus, is penetration by any means feels like it was interpreted by the nerves as a burning pain, a stabbing pain, instead of pressure. So we want to get the nerves into transmitting and communicating the correct information that the pelvis is sensing to the brain, and not the heightened pain information. This is delving a little bit more into the vulvodynia and vestibulodynia. Often that's where the nerves get even more overactive. I have had vaginismus patients who don't have the burning and stabbing pain, just have muscle pain internally.
So in other words, the pelvic floor still goes into spasm.
Does.
But there's no, as you say, stabbing pain or a burning pain. So where would the pain be experienced? Just, are you talking about just the muscles tensing up, and there's no possibility of penetration?
Correct. It almost feels like it's closing. That's what most of my patients say to me, and that's what I get the feedback from when I'm treating them, is that these muscles close up so tight that you're not even able to get one finger in, or a small dilator inside. It may and may not be related to the nerve pain. As we know, everyone experiences pain differently. Some people will have no burning with their vaginismus, and some will. So we can't blanket say that it will be the same for everybody. Vaginismus without the vulvodynia and vestibulodynia is very, very tight pelvic floor muscles, which does still cause pain, and is very much associated, as I said earlier, with fear and anxiety. There isn't always a history of trauma, but there could be a history of trauma. There could be a history of a very conservative upbringing, a history of not being able to discuss anything below the belly button, feeling ashamed of what of your genitals, feeling ashamed of even being interested in your genitals as a grown teenager or a young person, and not being able to communicate that to anyone or get differing information or the permission to not be ashamed. And that can result in a lot of fear and anxiety around penetration, especially the first sexual encounter.
For sure.
Yeah.
So we're going to get to primary and secondary vaginismus. Okay, let's do it now.
Okay.
So some of my clients have experienced primary vaginismus. That's on first virgin.
Yes.
The woman is a virgin and experiences pain on penetration, or painful penetration after the first experience.
Right.
Then I have clients who've experienced painful penetration after, let's say, a baby.
Correct. Yeah. Yeah.
And maybe not even from a traumatic birth,
Yes.
or from an episiotomy. That's when they cut the perineum. So, can you explain that in a little bit more detail?
Sure, absolutely. So primary vaginismus would be that from the first encounter and never being able to have pain-free intercourse, often involved with not being able to use a tampon, and then that first sexual encounter where penetration is involved, not being able to even have intercourse. Either it's very painful, gritting your teeth, bearing it, not enjoying any experience, or just completely unable for anything to go inside. And unconsummated marriages, unable to fall pregnant, and then obviously delving into going for IVF or assisted pregnancies. Secondary vaginismus would be when somebody has had normal pain-free intercourse, possibly even decades of pain-free intercourse, and then something will happen, like it could be childbirth, it could be it's often hormonal changes which happens after childbirth.
Right.
So it could be perimenopause into menopause, a decrease in estrogen in your blood, and what that does to your vagina. So it might not specifically mean a traumatic event has happened. It might just be a hormonal imbalance. And it is a good idea to, when you've had pain-free sex in the past and things are changing with your body, definitely go and see your doctor, because blood test, check out your estrogen levels, a little medication, hormone replacement therapy, or alternative methods, alternative medicine can assist with the health and the lining of the vagina. So plumping things up, getting the tissue a little bit more rejuvenated and lubricated.
Yes.
And getting through that painful period and return to pain-free sex.
Well, I love lube so
Love lube.
much. Drink it if I could.
Really good lube.
So lube is always a beautiful, beautiful accessory.
Yes.
To keep very close by. It's not always the answer, but definitely when I speak to my couples and I say, are you using lube? They say, yeah, but we use KY jelly, and I'm like, oh, okay, that's not really lube.
No.
But when I introduce them to a beautiful silicone lube, which is my preference, sometimes it really helps a lot.
Yeah.
Especially for when hormonal changes are coming into play, together with creams from your doctor for vaginal dryness. Yeah, I love my lubes. Tell me about the use of dilators and vaginismus.
So what we do in our treatment of vaginismus is I work, as you said, in the My Sexual Health team along with the doctors, and often almost with every vaginismus patient, we've needed to work together to diagnose the cause and the best treatment, and it is individualized. Some patients will need to include the anti-anxiety medications. Some patients will need to include the sexual health therapist or the sexologist to work with some psychotherapy. Some patients will need to do the cream, which helps with the cream that is prescribed by the doctors and made by an integrative pharmacy, where they actually compound their own medication, and it would be specific to that patient. So I'm not going to give you a list of ingredients. The doctor would have to prescribe that, and that assists with that neural pain externally. It assists with some hormone changes. So that is the group of treatments, and physiotherapy forms one of those elements. And we use not only our hands to treat internally and externally, but we use the silicone dilators, which come in a set of 5 dilators, going from the smallest as number 1 to the largest as number 5. And these are then, the use of these dilators is taught to the patients on how to use at home, because there's homework to do every day. And when we treat as physiotherapists and then give the patients the dilators to do the continuation of treatment or therapy at home, that's when we get the best benefit and the quickest response or recovery from the patient. And it definitely is something that is not easy for the patient to take on psychologically the first day, that, oh, I have to go home and use the dilator, and how am I going to do this? So a lot of education is involved around the dilators and teaching them how to do it, and using it the next size up together with the physio gives the patient confidence, and then they go home and continue this therapy at home. And often when the confidence rises and improves, they're able to move on to the next dilator, sometimes on their own, because they're feeling so good about the treatment, and they're feeling calmer about their body's response.
So what does the dilator actually do?
Okay, the dilator gives a circumferential stretch to not only the muscle tissue, the connective tissue, but the nerves as well. So we're getting a prolonged stretch or mobilization of that tissue as we ask the patients to insert the dilator and keep it in for 30 minutes a day. So that's where the longer period, it's a lot of time investment that these patients are putting into their health. But I try and encourage them to include this in their time that they're going to do a 5 to 10 minute meditation, as well as their diaphragmatic breathing, and possibly listen to a podcast or a TED talk or something that makes them feel calm. Maybe listen to some lovely music, read. It's a time where they do actually need to lie and relax and just really enjoy their time with their body.
So you can't be cooking.
You definitely can't be cooking. You definitely can't be cooking.
And then how long do they have to stay on the one size until they can move up to the next?
That would depend on them specifically. So I've had patients who would move through a 1 dilator per week, and patients who would move through 1 dilator every 3 to 4 weeks, possibly longer. It all depends on how their body's responding, and any outside influence, like stress, like work, like relationship, family, travel. There will be many reasons why they wouldn't be able to dilate or wouldn't want to for a period of time, and that's okay. What I've found is that patients would have struggled for a very long time. It might not be months, it might be years, it might be decades. And they come to me when they are ready. They don't make the appointment with me until they are ready. And once they've started the treatment, they often do say, gosh, I should have probably started this a long time ago. And I try to reassure them and say, but you weren't ready. You needed to feel ready in your head and your heart, and you weren't. And then they go, no, I wasn't. I was busy with some other stuff in my life. So it takes time to reach that stage where they are ready for treatment, and they take it on wholeheartedly, because that 30 minutes a day, that's a big time constraint. So they really do, their lifestyle needs to be ready for that.
Yeah, it's a commitment for sure. So now let's talk about the taboo. About around physiotherapy as a means to treat pelvic pain.
Yeah.
Where's the taboo?
I think the taboo is that most people expect physiotherapists to be treating sprained ankles and ACL repairs and hip replacements and things like that. Physiotherapists are not generally expected to be working internally at all. I've had so many occasions where I would be at a social event or in a doctor's appointment with my husband, say even for an optometry check, and we start talking about what I do for a living, and my husband loves to say, you know, that she's a pelvic health therapist. The eyes are open wide and the eyebrows are raised, and they're very, very interested to hear what I do, and then start asking more questions, which is great, because if I can educate especially doctor friends who know nothing about pelvic health, specifically physiotherapy and pelvic health, they're all aghast that I should be venturing internally. And when reassured, they think, God, that's amazing, wow, I can't believe you do that. Or they're quite grossed out, which there comes in the taboo. These are medical professionals who don't know that physios can do this and don't know that this is something that patients really need. It is a taboo. There's obviously even people who are not in the medical field, they're probably more aghast. But it's been interesting educating friends and colleagues and seeing that from their side, from their perspective, and being able to answer their questions, because I think then they'd be able to ask their close friends and family and patients the right questions. I find that so many times, one example is a newly postpartum mom attending her 6-week gynae checkup, or the midwife checkup, or the baby nurse checkup, and she's sleep deprived, and she is having painful sex, even though it's probably once every now and then in a blue moon, and nobody's asked her, how are you? How have you recovered? Are you having sex yet? And is it pleasurable? Is it painful? Are you able to orgasm? Because that is an important way to tell whether her nervous system is working correctly. It's not just about, glad you're having pleasure, but are you able to? Because that is a symptom of the nervous system not working properly, and maybe her hormones not working properly. So checking in with patients, and specifically maybe a GP visit, even a ped visit. If you check in on a baby and mom looks a little distraught, maybe just check in with mom. If you're the baby nurse and you're weighing the baby and giving mom breastfeeding advice, and mom looks like she might be on the verge of tears, maybe just ask her.
I can't remember any one of my nurses, my ped nurses, turning to me and saying, are you having sex? Are you enjoying it? And are you having an orgasm?
Definitely not. That's not happening yet. Maybe we can get them to. That's not happening yet.
No, definitely not. So you'll meet a patient, a woman, and so also let's talk about gynecology. A lot of women are turning to gynecology now, right? There seems to be more women doctors who are doing gynecology. And I have a woman gyne.
Me too.
I would much prefer a woman gynae, obviously, and that's why I suppose it's almost the same as going to a gynecologist, right? What I'm saying is a woman gynae, because I'm just thinking about my own stuff, about having an internal examination by a woman, but when it's like medical, it feels better.
Yes.
And this is my stuff, and I'm openly admitting it, because we're talking to everybody, you know. So do some of your clients freak out when you tell them that you're going to be doing an internal workout?
What I do is, first of all, I make it clear that there is no obligation to an internal assessment or treatment. It is not a have to do thing. Obviously, it gives me a lot more information if I'm able to assess internally and treat internally. However, not everyone, again, is ready for it. I have had many patients, I'd say about many patients, 10 to 20%, who refuse an internal assessment and treatment, and that's absolutely fine. We start working externally, and that's often when I'd need to refer on to either the therapist or the doctors to get their assistance in treating. Often this patient needs to reach the point where they ask for the internal assessment. So they know it's possible, they're not ready for it emotionally or physically, and they wait until they've seen through some therapy, some medication, but time, sometimes it's just time, and then they come back and say, right, I'm ready now. For the most part, my female patients are asking for an internal assessment. Yes, there's always trepidation. There will be those patients who are really nervous, and we go slowly and carefully and gently, and at any stage that patient is encouraged to say, I've actually had enough now, or please can you stop, I need a break. I try not to linger for too long, because it is an invasion of their space and their body, and having been a patient myself during training, I think it's very important that physios, when they are studying to learn to do internal work, that they are patients themselves, because you need to know what this feels like.
Absolutely.
It's not your knee or your ankle or your shoulder or your headache. Even dry needling, when we did dry needling courses, we would practice on each other. You need to know what that feels like. So that's very...
Yeah, and that's the disadvantage for male doctors, gynaes, physios as well. They don't get that experience. They cannot. So, and I think women are needing that feminine touch, that feminine care, that feminine empathy.
I think so too.
And that's why a lot of people, I think, are going to female gynaes.
I think so too. There is something about knowing that the person treating you and asking the questions understands exactly what it feels like. They may not have had that specific complaint or injury, but they understand what your body feels like, because they have the same body parts.
And they also understand the same fear around intrusion. And it is, in a way, it's an intrusion. Even, when you're having sex for the first time, for the guy, it's divine. For a woman, it's like an invasion of this object, unfamiliar object, and it's very scary. It's for me, it makes me feel a lot more secure and comfortable and safe if I'm going to somebody who knows how this feels.
I agree. I'm fully into that. When I had my babies, I went to a male gynecologist, and he was wonderful, and I didn't know any differently, and I hadn't started to do any of this pelvic health physiotherapy, and I wish I knew then what I know now. And I think he did a fabulous job. But now that I've worked in pelvic health, and I'm working with female gynecologists and see a female gynecologist myself, I almost wish I'd had my babies with a female gynae, an obstetrician, for their understanding and their knowledge and their experience of it themselves and their empathy. It is just a different experience.
Absolutely. And that's why we're doing this show. We're breaking the myths, we're breaking the taboos. We are, we're just appealing to women and men, sort of, we're educating both. And to make it accessible, we're making information accessible to the public. That this is available, you don't have to suffer.
Absolutely, there is so much help out there. It's if you start Googling and start asking questions, a lot of information is going to come up. Don't let Google diagnose you. Absolutely. Just go to Google for contacts.
Exactly.
Go to Google for contacts and find the right person to ask. They might not be the right person to treat, but they might be the right person to put you onto their referral network.
Exactly.
And get information from, and keep looking until you found what you need, until all your boxes are ticked, until you found what you are looking for.
Do you find that you are often faced with this challenge of having to give therapy, or people telling you their stories, and then you're kind of, and how do you feel about doing that kind of thing, going into that therapeutic space?
I must be honest, I feel a little overwhelmed.
Yeah.
I'd like to do more education courses on the therapy side, but I still don't think I'd be able to act as that therapist. It would really be on the what not to say.
Oh God, yes.
And that's where what I often say to my patients is, I don't have the right words. I'm hearing you, I can see that this is traumatic, or I can see that you're really struggling. I'm not the therapist, I don't have the right words, but I think you should see somebody, or but let's try and do some mindfulness at home about it, maybe try and write a little journal about what you're feeling and where your feelings are coming from, and you don't need to show me, but let's get you the help that you do need, because we can't leave it like this. It's definitely part of it. I do feel that that's where I can't step into those therapists' shoes, but hopefully bring that person bring that patient to the right person, the right professional to help them.
Yeah, I get that. Because I do see a lot of clients with vaginismus.
Right.
A lot of them feel as though they're broken. Some of their partners are very patient. In fact, a lot of them, their partners are patient. Not too many of their partners are blaming them or telling them they're broken, although there are a few.
Yeah.
And then when they land up on my couch, they cry because they feel broken, and that they're the only people that are suffering from this. They also don't understand it, they don't know what's going on.
Yeah.
So the minute we give it a name and I explain to them physiologically what's happening to their bodies, it makes sense.
Yeah.
So when we go back into childhood stuff, even if there is no real trauma around rape or, God forbid, sexual harassment, sexual violation, and so on, there's definitely, as you said, very conservative environments. There's been body shaming, they feel guilt around their bodies, there might be some first sexual experiences that didn't go so well, and so there's definitely a link. Psychologists used to think that it was just all in the head.
Yes.
But we know that it actually is definitely a physiological experience, that it's an involuntary.
It is involuntary, yeah.
The body involuntarily goes into spasm. It's not that the brain tells,
the fear and anxiety
The fear and
involved.
anxiety
The fear and
is
anxiety, it can't
It's
be
not
controlled,
conscious,
and
yes.
then the response to the fear and anxiety is these muscles go into spasm in anticipation or apprehension of what's about to happen.
Correct.
So at the time, like, there's foreplay and there's excitement, and she's feeling like she's actually into it and she wants to have sex, and yet at that moment of potential penetration, that's where her body goes, oh no, and it's completely involuntary.
Yeah. She's not doing anything.
It's a physiological response, and her muscles go into spasm.
Correct.
And there is very little that she can do at that time. She cannot control that at all. But over time and through treatment, medication, therapy, mindfulness, physio-dilators, we can absolutely make a huge impact in treating vaginismus and pelvic pain.
100%. We did chat about erectile dysfunction.
Yes.
And if you are able to treat men with erectile dysfunction as well.
Yeah. So I don't personally treat men with erectile dysfunction. However, most pelvic health physios do treat both men and women. There is another specific course on erectile dysfunction which I have not completed. Erectile dysfunction needs to be diagnosed by the doctor and assisted with testing hormone levels, and then treating hormone therapy, and dealing a lot again with anxiety and stress. That's often when things like erectile dysfunction come up. Physiotherapists would address the pelvic floor muscles and the posture and the lumbopelvic, so your lower back into your pelvis, the position, the tension in muscles. They would be able to release those tight muscles externally and teach the patient how to improve their posture, which will include strengthening exercises not only for the pelvic floor muscles, but for the gluteus maximus muscles and the abdominal muscles, changing the way that men use their body, even in a sitting position. Erectile dysfunction is then affected by the way that these pelvic floor muscles work. So stronger pelvic floor muscles will result in a stronger erection. Biggest thing though is the hormone therapy. So testing and getting onto the correct dose and continue with that. Of course, the stress is a big one for me. So
huge.
Yeah.
So for premature ejaculation, how would one treat that? Is that a lot of breathing? Teaching how to delay?
Could help. Definitely the breathing exercises would help. Again, the mindfulness and meditation and diaphragmatic breathing exercises, along with learning to use the pelvic floor functionally and strengthening the pelvic floor. And then as far as I'm aware, the premature ejaculation comes on when there is a fear of how long am I going to be able to contain or hold this erection.
Right.
So that would come then with post hormone therapy, with the treatment, being able to feel more confident in what the hormone levels are doing and the therapy is working, and then doing the mindfulness and the breathing and the pelvic floor exercises. So again, it's a whole multidisciplinary approach.
Right.
One would probably not work without the others. We need to look at it from all perspectives.
Wow, so interesting. I love this. I love the medical side of it as well as the psychological, sociological side of all of it. I just absolutely love it. And that's been very, very enlightening. I have done the MSH training, so I do have more of an understanding, but yet I also know when to refer to you, and you're an absolutely great resource, and I so appreciate you and what you do.
Thank you.
Really, really I do. And thank you for making your time available. I know that you're very busy.
No
I really
problem.
appreciate it.
Thanks for having me, and thank you for bringing up topics like this and doing your podcast, because I think the more we get word out and the more you educate your listeners, the more they'll educate everyone they know.
Absolutely.
So kudos to you, Tracy.
Thank you. And for breaking the taboos, and getting the message out there that we really need to talk about sex and sexuality, and nothing is taboo if we just have these conversations. So thank you again, Carren.
It's a pleasure.
And thank you to our listeners for making the time to educate yourselves, and we'll see you next time for the next episode.